Good morning and sit down, please. We can wait for 2 seconds. Good morning and welcome to the first part of the doctoral examination of CAMMed Joachim Thorkildsen, which is the trial lecture of the Faculty of Medicine, University of Oslo. Present today is the candidate, the committee, and the audience. My name is Associate Professor Thomas Kipsgård, and I will share the trial lecture. The evaluation committee consists of Professor Lee Jace from the Royal Orthopaedic Hospital in Birmingham, UK. Senior consultant Mikael Skorpil, Karolinska University Hospital, Stockholm, Sweden. And Professor Kjersti Flatmark from the Institute of Clinical Medicine, University of Oslo. The purpose of the trial lecture is for the candidate to show his ability to disseminate research-based knowledge. In addition, the candidate shall show an ability to present the lecture topic within the available time frame, which is 45 minutes, master presentation techniques, audiovisual aids, and handle questions and comments from the audience. The trial lecture lasts for 45 minutes, and up to 50 minutes are set aside to questions and comments from the audience. If anyone wants to present any questions, they just have to tell me after the lecture. If the trial lecture is approved by the committee, the candidate will defend his thesis after a short break, after a long break, actually. So now I ask the candidate to take his place and present the lecture, which has the title, Discuss Diagnosis, Imaging, Treatment of Pelvic Bone Tumors. Good luck.
Thank you. Okay, so you can all hear me okay? That's the visual aids and you can see the screen. So let's start. Dear committee, dear colleagues, family and friends, this is the first time we've been allowed to meet physically at these events for 18 months. It's so good to see you all here today, for real. The subject I've been given today is as follows: discuss the diagnosis, imaging, and treatment of pelvic bone tumors. We have to press play. So we will start by defining the task. We'll talk a little bit about, in general, about the tumors and the pelvis. We'll talk more about key features of the diagnostic process, focusing on frequency and the importance of age and location before addressing their symptoms. We'll then discuss typical imaging findings as exemplified by 3 cases before we go on to discuss the treatment of pelvic bone tumors. Ewing, osteo, and chondrosarcoma are the 3 classic diagnostic groups from what we call primary malignant bone tumors. These are tumors that arise in bone and spread from there, primarily to the lung. In order to limit the topic, we are not going to address multiple myeloma, which is a hematological malignancy, and not metastatic bone disease, which actually represents the true volume of pelvic malignant disease in the pelvis. I will primarily also address local treatment. We're not either going to talk about the sacrum bone, this because the diagnostic spectrum, imaging and treatment of tumors there are so different to that of the rest of the bony pelvis. Also, benign and locally aggressive tumors occur in the pelvis, but we're not going to address them either today. All this to be able to talk a little in depth about the topics that remain. So let's have a look down the microscope at the tumors we've chosen to discuss. We can't have a sarcoma presentation without pink and purple histology slides. First, on the left, we can see a pretty chondroid matrix, background matrix, moderately cellular and scattered what we call binucleate cells. No mitosis is visible. This is what we call a grade 2 chondrosarcoma. It looks like cartilage, hence its name, but it arises in the bone marrow or on the surface of a bony protrusion called an osteochondroma. And so, in fact, the only place in the skeleton it does not arise is in the functional cartilage at the end of the bones. For number 2, we can see a lace-like osteoid formation, this pink substance here, which is immature bone. This encompasses clearly enlarged and atypical osteoblasts. And again, this we also see some chondroid tissue or cartilage tissue come down here. So this is a chondroblastic osteosarcoma. Hence, and again, this tumor produces or consists of premature bone or osteoid, hence the name osteosarcoma. Osteosarcoma has many subtypes with differing behavior, but today we're primarily going to talk about the conventional high-grade or aggressive type. Up here on the right is Ewing sarcoma, which is an exception to the rule, being named after an American pathologist in the 1920s. We see typical sheets of round, small blue cells, no cytoplasma, this salt and pepper picture, and this is the only entity that has a clear diagnostic molecular marker. Over 90% of Ewing sarcoma contains a typical T2211 translocation. So let's move on and talk about the pelvis. The bony pelvis consists of, in simple terms, of 2 equal sides, consisting of the ilium and the pubis and the ischium bone. They together form the pelvic ring with a fibrous joint at the front at the pubic symphysis and connecting them at the back to the sacrum on both sides via the sacroiliac joints and the spine. These bones are important both because treatment of the differing bones has differing consequence, but also because our chosen tumors have a predilection for the different areas of the pelvis and as such are important diagnostically. So what are the functions of the bony pelvis? Locomotion, that is the transmission of load through the trunk to the lower extremities during movement, as well as during sitting. Being an orthopod, I put this first. Maybe more importantly, the pelvis is of course the bony limits of the birth canal. We've all come out that way. Of note, females have on average larger dimensions of the bony pelvis compared to men. The pelvis is also important for support and protection of the abdominal and pelvic organs. And lastly, the bone marrow constitutes a considerable functional reserve in the bone marrow, both with regards to hematological and immunological systems. The bony anatomy can, of course, not be considered alone, but rather with all the important muscular attachments, blood vessels, nerves, and internal organs. The distance into the pelvis is also unique and challenging. Another key feature is this described by these photos. In cross-section, the pelvis is very different to that of the long tubular bones of the extremities. These are the measurements of the cortex, the thick, strong bone of my own tibia, femur, and ilium. So on the right, we have the tibia. It has a cortex of 8 millimeters. This is my femur, my thigh bone. It has a cortex of 7 millimeters. But my ilium, avoid looking at these degenerative middle-aged cysts here, has a cortex of only 3 millimeters. In adults, from a tumor perspective, in adults, most bone tumors uncovered in the pelvis are in fact malignant, as opposed to the thigh bone in adults where most is benign. Also in contrast to bone tumors of the pelvis in children where most are benign. The complex anatomy of the pelvis relates to challenging treatment and higher rates of complications, whose consequence is also more severe or serious. But maybe the most particular point regarding the pelvis is that the prognosis of our chosen tumors is more sinister when it occurs in the pelvis compared to other locations. They have a higher tendency to metastasize. The overall survival at 5 years for pelvic chondrosarcoma is in the range 70–80%. For Ewing sarcoma, 60 to 70%, and for osteosarcoma as low as 30%. Let's move on and look at the diagnostic pathway. Luckily for us, there are national and international guidelines for both the investigation, management, and follow-up of patients with sarcoma of all types. These are very useful, but they're challenged by the increasing diversity of many sarcomas. They are by necessity held at a fairly general level. The premise of successful sarcoma care is that it happens in what we call reference centers, with a wide range of subspecialists taking part in an integrated multidisciplinary patient care pathway. This has been documented as a key step for improved diagnosis in many countries. It's important also to say that the diagnostic pathway for all sarcoma is a complex complementary interaction between clinical presentation, statistics, radiological features, key microscopic features, and an ever-increasing array of molecular analysis. The details of all these things are far too many to go through today, but all these corners and the communication between them has to be well-functioning for the best possible performance of a sarcoma team. While some diagnoses have a very clear diagnostic molecular marker, such as Ewing sarcoma, for many subtypes, the diagnostic process still relies heavily on qualitative features at radiological or pathological assessment, and is such both very difficult and open to a degree of uncertainty. Let's look at how common this is. From the last 20 years in Oslo, we've had 152 pelvic bone sarcomas registered in the tumor database, which covers about 80% of the Norwegian population. This averages just over 7 cases per year, but this is a rare illness, so these 7 don't come regularly during a year, but they come in fluctuations, and these numbers vary from institution to institution. In absolute numbers, you can see that nearly 40% of these are chondrosarcomas, twice as many in number as those for Ewing and osteosarcoma, which are roughly similar in frequency. And why are we spending time on this? It's interesting, of course, for a sarcoma nerd like myself, and it says a lot about the challenges to patient care and research in the field. A clear and concise history of symptoms and findings is a good entrance to the diagnostic pathway, and the entrance to the diagnostic pathway is key. Earlier radiology or histology may seem irrelevant, but can often unmask previously undescribed changes that can give useful biological information. There are a number of rare syndromes that predispose for different types of chondrosarcoma, and of course these are highly relevant. One of the dramatic long-term side effects of radiotherapy is what we call secondary cancer. And for radiation given, for example, to gynecological or gastrointestinal cancer, this can be a pelvic bone tumor. In fact, in series of pelvic osteosarcoma, about 20% are thought related to radiation. Paget's disease is a disease of bone turnover, very rare in Scandinavia, but much more common in the UK. And this has been linked to an increased risk of osteosarcoma development in late adulthood. The Birmingham Research Group, represented here today, always have really great titles for their papers. And one of their radiologists has a paper entitled The 10 Commandments for Diagnosis of Bone Tumors. His first commandment is recognize the importance of the patient's age. So a really big part of diagnostic tumor radiology is simple statistics from earlier observations with pathological correlation. Simply put, what is likely to occur in this bone or in this part of the bone in this age group of this patient. So we can see here that people in their 20s or up to their 20s are much more likely to have different tumors as to people in their 50s or 60s. This gives us a visual aid to consider what we call the differential diagnosis. So there are a number of what we call benign bone lesions or locally destructive bone lesions that can be either incidental findings or the cause of symptoms requiring treatment, colored here in blue and green. These are conditions that to varying degrees displace and destroy bone locally, but do not have the capability to spread to other places, for most part. Lastly, there are malignant types of disease in red, such as multiple myeloma or metastasis from other cancer forms that can destroy bone in the pelvis and mimic symptoms and findings of a sarcoma. Infection is not on this diagram, but can be an important differential diagnosis to sarcoma, especially Ewing sarcoma. Both Ewing and osteosarcoma here with the red arrows occur primarily in childhood and the teens and very early adulthood. If anything, Ewing sarcoma a little bit earlier than osteosarcoma. Chondrosarcoma, on the other hand, down here, occurs primarily in late adulthood. Here we can see similar national cohorts for osteosarcoma for Norway and England. Now there's a clear peak in the teens and early adulthood for both nations, but we can see in Norway that there is this plateau that keeps on going. This is different than for Ewing. The Ewing curve goes straight down. So there's this plateau and keeps on going. For England, however, the plateau reaches another peak again, and this is in the age group where, relatively speaking, osteosarcoma is more common in the pelvis. So it's thought that this difference is in part explained by the presence of Paget's disease in the UK, which we, like I said, hardly see in the Nordic countries. So we have to be aware that the numbers that we find in the literature might not be representative of the nation that we're living in. Vide from Stockholm studied the clinical presentation of osteo and Ewing sarcoma, but for all locations. So most common presentation is pain, with or without a mass. This can be in the lower back, or in the flank, around the hip, the buttock, or the groin. Sometimes it's just gradually increasing, while other times it's more intermittent and much milder. We can look at data from my own research on pelvic locations only for chondrosarcoma, and we can see that pain also is the primarily mode of presentation. Alternatively here, in fact, 15% are what we call incidental findings. You find them when you're looking for something else. The difficulty, of course, is that there's no magical cancer pain that's different from all other causes of pain. So to distinguish this from sore muscles, slipped discs, arthritis, the pains of life, if you like, is very difficult and challenging. It's also important to know that sarcoma doesn't show up on a blood test. So the key to the diagnostic pathway is therefore radiology, and just as importantly, that this is interpreted by the right people. Diagnostic delay because of this difficulty in the clinical picture is a common problem in the world of sarcomas, and it's been studied specifically for pelvic bone sarcomas. These diseases are so rare that they often are not included in the differential diagnostic pathway initially. A German group found that on average for pelvic bone sarcomas, they have symptoms for about 10 months, and they found that for 44%, there was a median 7-month delay even after they had already been in touch with the health service. Looking specifically at the pelvic chondrosarcoma in Norway, their average time of symptoms is 15 months, but with a range from half a month to 10 years. Let's have a look at 3 cases to make it a bit more concrete, and we can follow them through their course. The first is a 21-year-old female. She's had pain for about 10 months. It started quite diffusely in her lower back, around her flank, and then it's been intermittent, but then gradually increases. She's been to see 2 chiropractors, and by the time this is really intense, radiates to her back, and she needs morphine painkillers, a local physiotherapist notices a big mass and sends her to an MRI and then to us. Case 2 is also a girl, but younger. She's 16. She's had different type of pain for a year. It's been aching, diffuse. It's been around her right hip, but she's also had pain in her left hip, her knees, and her hands. So in fact, she's been referred to a rheumatologist, but luckily the right hip has been a little dominating, so they do an MRI of her right hip, see a lesion, and refer her to us. Case 3 is a 67-year-old male. He doesn't have any symptoms, but as men in their 60s, he's got a slightly elevated PSA, and so he's checking out his prostate and does a MRI of his prostate, which finds a lesion in his acetabulum. Imaging. Tumor radiologists in the room here today, they need to master the technical engineering and physics language of radiology, first of all. They also need to master descriptive radiology, which is indirectly translating a pattern and speed of growth of a tumor by observing how it influences and relates to the bone and the periosteum, which lines the outside of the hard cortical bone, and does its best to contain the tumor in its place. These are descriptive terms that, of course, are open to interpretation, but in fact, together with statistical tools of location and age, they're key to the interpretation of images. They also need to understand statistics, as we've talked about today, in addition to understanding the predicaments and language of surgeons and oncologists alike. What we call plain X-rays can in the limb diagnose bone tumors pretty accurately in nearly up to 80% of lesions, but this is much less so in the pelvis. It can, however, give important tips with regards to the degree and pattern of bone destruction, as well as mineralization in both the bone and the soft tissues. A lower threshold for performing a CT or MRI in the pelvis is therefore mandatory. CT is key in describing the pattern and extent of cortical destruction, the hard bone, matrix mineralization in both the bone and the soft tissues, as well as the periosteal reaction. MRI, on the other hand, is better at defining the nature of the matrix with regards to fat, blood, fluid, cartilage, as well as the soft tissue extension and the limits of these. It's also important to assess the invasion of nearby joints or anatomic structures. The patient, you have to remember, in the pelvis is their own control. It's very fruitful to compare the disease size to the other healthy side, left versus right, or if you have previous images. Biopsies are often necessary to differentiate these tumors definitively, with the possible exception of chondrosarcoma. Using ultrasound or CT, this can help guide us to areas of the tumor that is most likely to give us representable tissue. A biopsy produces, however, contamination or seeding of tumor cells, and the area of biopsy needs to be removed at final surgery. It's therefore has to be done in line with the planned incision for surgery, and doing this with a needle from the outside under guidance of imaging, rather than a small operation, causes less contamination, gives us the answer in about 90% of the cases, is safe and cost-effective. Internationally, there is a broad consensus that a traditional CT scan of the chest is the best imaging choice when looking for bone sarcoma metastases to the lungs. Guidelines state the need also for a bone scan to detect bone metastasis. For Ewing sarcoma, the introduction of what's called PET-CT has shown to demonstrate bone metastasis with more sensitivity, specificity, and accuracy than a traditional bone scan. This is a traditional low-dose CT scan overlaying a functional isotope scan where radioactive sugar molecules show up as increased activity where sugar metabolism occurs. Here are these yellow dots. It also creates a value in its intensity called SUV, standardized uptake values. Radiological response. This is an attractive surrogate measure for chemotherapeutic effect. That is the chemotherapy working? For both osteo and Ewing sarcoma, it is an important prognostic factor in how much of the tumor which has become necrotic, or alternatively, how much is still alive after chemotherapy. Ewing sarcoma patients still tailor their treatment in relation to this answer, and it would be very helpful to predict this already at radiological examination. It's also, of course, vital to good patient information. They want to know after the scan, is my chemotherapy working? There are no clear validated systems for this in our tumors. There is a system called RECIST criteria, which relies, amongst other things, on size. But for our tumors that we're studying here today, the matrix, the substance of them, tends to ossify, and as such, not produce much change in size. So routinely, instead, we look for new lesions. We address the size of the tumor nonetheless. We assess retraction of the soft tissue extension, as well as mineralization of both the bone and soft tissue part of the tumor. Other changes in MRI signaling, like the appearance of fat, cystic changes, and fibrosis, can also be of value. We assess changes in edema or swelling around the tumor as well. MRI is something that is developing very quickly, and there is something called dynamic contrast enhancement, which is really all about the kinetics of how contrast is taken up and eliminated from a tumor area. This gives us a kinetic graph where both the timing and the peak and the pattern and slope have all been extensively studied, as well as something called diffusion changes in other sequences. A group from Seattle have studied response by PET-CT, and they've tried to compare it directly to histological response, which is promising but not very precise. But on the other hand, if they compare it directly to progression-free survival, it's much more promising. So let's have a look at the initial CT and MRI for case 1. Up to the top where we see her initial scans, we can see an expanded osteolytic posterior iliac bone, but with partially intact cortex and a large soft tissue mass here on both sides on the MRI. We can see ossification both in the bone and in the soft tissues on the CT. We can see again here that it crosses the sacroiliac joint and has this typical radiating pattern inside. So this is an osteosarcoma. Let's look at the response pictures down here. We can see that the size is really much the same, but there is clear ossification both in the bone and in the soft tissues on the CT, while on MRI, we can see that there are small areas of fat displaced by these little white areas in the big dark tumor here. They were not there previously on the similar sequences. So case 2, we can see much more subtle changes on the CT. There is this slightly moth-eaten osteolysis. This is the same case that we saw an X-ray of, which was described as normal. We can see a single-layered periost reaction, but the MRI shows a soft tissue component both on the inside of the pelvis here and on the outside. This was a Ewing sarcoma. Looking at the response evaluation after chemotherapy, we can see that there's a gentle ossification in the tumor, but most importantly, the soft tissue component on the outside is disappeared. Unfortunately, the one on the inside is retracted, but has not disappeared. Case 3, this was the man with the prostate. We can see here this typical pattern and signaling of a chondroid tumor on MRI, on CT with the osteolysis and with the cortical destruction, and again on the MRI, the soft tissue component seen here extending on the inside of the pelvis. So this is typical of a central chondrosarcoma with the soft tissue components. Let's talk about treatment. We're not going to talk much about chemotherapy, but we have to state its importance. As a rule, for both Ewing and osteosarcoma of bone, they're both recommended treated with high-intensity chemotherapy with multiple agents. So without this treatment, the long-term survival for both these diseases in all the cases is in the order of 5 to 10%. For chondrosarcoma, on the other hand, which isn't treated with chemotherapy because it doesn't work, the long-term survival is 70%. This highlights the extreme differences in biology between these tumors. Now, traditionally, for osteo and Ewing, this is a plan. You have lots of courses of chemotherapy, and then surgery and or radiotherapy comes in, and in this case, chemotherapy goes on depending on whether you have poor or good response. We will spend more time discussing radiotherapy. As you can see on the left, what we call a photon field, traditional radiotherapy, where the central red dose, red and orange areas, is where we deliver the dose that we want to the tumor, in this case with a scale here 54 gray. But a large area around here in the blue and greens show that quite a large healthy area is also receiving lesser doses of radiation. On the right here is something different, something called proton radiotherapy or a proton field. You can see here that there is much less blue and green coloring around, meaning that less surrounding tissue is getting irradiated. This is due to the differing acceleration and deceleration properties of protons. We're going to start to talk about treatment for Ewing sarcoma, and we're going to take a little look at the history, because I think it can make us wiser as to the dilemma that we face today. In the 1920s, we thought most of these tumors were osteosarcoma, and we knew that radiotherapy didn't really work that well. So an American pathologist, James Ewing, noticed that some of these tumors looked different in the microscope, and they occurred more frequently in the diaphysis as opposed to the metaphysis, and in the pelvis. And they looked a bit different. So to test whether they were different, he gave a 13-year-old girl with a tumor in the ulnar bone radiotherapy, and it worked. He then described 20 other cases, and the standard treatment of these became radiotherapy. They argued against surgery since it had morbidity, and nearly everyone died from metastasis within 2 years. With the introduction of adriamycin in combination with chemotherapy in the early 70s, oncologists started getting control over systemic disease. It was still radiotherapy first, chemotherapy afterwards. In early protocols, however, most pelvic cases progressed, so the pelvis was key. This was due to the toxicity of radiation to the hemipelvis, hampering the delivery of chemotherapy. So this led again to the introduction of neoadjuvant chemotherapy, giving it before the local treatment, because then they could achieve systemic control. But having systemic control, they also needed to address local control again, and more prolonged local control, and surgery became more interesting. Surgery was, however, not really discussed in relation to morbidity, but it was rather discussed for cases where radiotherapy had less effect or challenging, which was really a different discussion than what we're having today. The literature regarding the role of surgery and radiotherapy in a modern setting is very extensive and somewhat conflicting, but there are two questions. One, is surgery to be combined with pre- or post-op radiotherapy, either selectively, just to some with a poor margin, or non-selectively to everyone? And the second question is, should surgery be replaced by definitive radiotherapy for some patients, in particular the pelvis? Given non-selectively, that is combined routinely with surgery, rates of control at 3 or 5 years for both photons and protons is in the range of 95 to 100% for pelvic Ewing sarcoma. In the setting, however, of selective radiotherapy, it appears to be associated with a reduction in the risk of local recurrence by about half, in a big European Euro-Ewing trial from 33% to 14%. If we look at the local control for definitive radiotherapy, series with photons describe results with quite a big variation, varying from 40% to the 75-80% bracket, while the most recent proton series actually describes 90% local control. This is, of course, very simplified and doesn't entail the difficult discussion of early and late morbidities or toxicities from both surgery and/or radiotherapy. Osteosarcoma and radiotherapy. This is widely recognized to be a tumor resistant to radiotherapy. That is, we think it doesn't work. I made a big table of all the articles that I read, and with a heavy heart, I reduced it to this. Numbers from highly specialized radiation oncology centers, primarily using carbon ions or combination carbon photon therapy, describe up to 50 to 60% 5-year local control of pelvic osteosarcoma, which surprised me and which is inspiring. This is both for definitive treatment or those undergoing a biopsy only, as well as those using it in addition to surgery. Chondrosarcoma is, again, broadly considered to be resistant to radiotherapy, and for the pelvis, there is the least study of this. Radiotherapy for chondrosarcoma, on the other hand, is largely studied for head and neck locations and some to the spine. There are, however, a few series from highly specialized centers reporting what we call observational series with the addition of photon radiotherapy in close margin situations. You're a bit close to the tumor than you'd like to be for high-grade aggressive chondrosarcoma in amongst the pelvis. And they describe it giving an additive effect on local control, but without real comparison in their series. So, in Oncologists We Trust, these four, who most of you are here today, they're about to get a new toy. Outside in the big hole you saw coming in is being built a proton center, Norway's first. It'll cost about 250 million kroner, but it's still only half of a jet airplane, of which we've ordered more than 50. Let's talk about surgery. Surgeons talk about surgery. It's very important to say or discuss what is the aim of surgery, and it may seem simple, but it's not. I've tried to summarize it by this sentence: adequate margins with durable reconstruction with acceptable morbidity. But what is adequate, durable, and acceptable? It's very difficult to predict, first of all, and open to interpretation, both from us as healthcare professionals and, of course, for patients undergoing therapy. I think really that this is the crux of what we call personalized medicine, a personalized treatment strategy. To be able to evaluate surgery, we need a language to describe how much of a safety zone we have to be removed with the tumor. So the Enneking system says that if we enter the tumor in any way, we call it intralesional. If we're very close through what we call the reactive zone, we call it a marginal margin. And if the tumor is covered in a layer of healthy tissue, we call it a wide margin. If we remove the whole segment that's afflicted, the whole bone or the whole muscle, we call it a radical margin. Since this introduction, we've, however, found that both for marginal and wide definitions, the use of these terms is quite variable and interpreted differently. So more often now, many centers use the residual tumor system, which describes our certainty of having removed all of the tumor macroscopically or microscopically. So if the tumor is covered in a layer of healthy tissue, we call it an R0 resection, while if we're unsure or if we think there could be residual microscopic disease in the patient, we call it an R1. We always aim for an R0. These margins are primarily defined by the pathologists. There is a clear degree of uncertainty because these are large, complex, three-dimensional specimens where the pathologist takes out sections here and there, particularly where we're most worried about the margin, but they can't look over the whole tumor with a microscope or examine the patient on the inside. Anyway, what margins do we need for our tumors to avoid local recurrence? For chondrosarcoma, the Birmingham group again have studied the absolute distance of a margin in the pelvis and concluded that for central pelvic chondrosarcoma, we need more than 2 millimeters for reliable control. But for another type of chondrosarcoma, which is more slowly growing, called peripheral pelvic chondrosarcoma, 1 millimeter is enough. For osteosarcoma, the Birmingham group again have studied absolute distance in high-grade osteosarcoma of multiple locations and concluded that more than 2 millimeters is necessary. But looking at pelvic osteosarcoma more specifically, Parry et al. Could not find a clear correlation, while a meta-analysis concluded that what we call an adequate or a wide margin had less local recurrence than marginal or intralesional margins. For pelvic Ewing sarcoma, however, distance hasn't been studied, and the findings of different terms of margins are much more variable. We have a Scandinavian work by Hessler et al., which found that an R0 resection was related to an improved overall survival. But on the whole, particularly for Ewing, but for all of bone tumors, there's a lot of work to do